Hi, welcome back. Well, in this time we will talk about a new section of the Obstetric and Gynecology, and it's about preeclampsia and eclampsia. So we know the maternal mortality rate in Indonesia is high, and the data from the 2012, the maternal mortality rate is 359 per 100,000 live births, and the latest data from SUPAS 2015 is 305 per 100,000 live births, and we have the target that is 183 per 100,000 live births. So it is a challenge for us. So what is the causes of the maternal mortality rate in Indonesia? The first is preeclampsia and eclampsia, or we can say that any hypertension in during pregnancy. And the second is because of the postpartum hemorrhage. And the third is heart disease. This is just the best three the causes of maternal mortality rate in Indonesia. So we are now talking about the pathogenesis of preeclampsia. We know that the placenta has always been a central figure in the etiology of preeclampsia because the removal of the placenta is necessary for symptoms to regress. So the key is to terminate the pregnancy, or if you don't want to be preeclamptic, just easy, don't be pregnant. But it's impossible, right? Every woman have the rights to be pregnant, and it's a blast for us. So the hypothesis is that the defective trophoblastic invasion with associated uteroplacental hypoperfusion may lead to preeclampsia. If this remodeling is impaired, the placenta is likely to be deprived of oxygen, which leads to a state of relative ischemic and an increase in oxidative stress during states of intermittent perfusion. So there is a model of preeclampsia that called two-stage model of preeclampsia. So stage 1 is incomplete spiral artery remodeling in the uterus that contributes to placental ischemia, and stage 2 is the release of anti-angiogenic factors from the ischemic placenta into the maternal circulation that contributes to the endothelial damage of the mother. So there is the definition of preeclampsia based on ACOG. So the preeclampsia is defined as new onset elevations of blood pressure more than or equal to 100 and 140 per 90 after 20 weeks of gestation, and associated with proteinuria, which is in 20 hours excretion is more than 300 milligrams, or new onset of blood pressure more than 140 per 90 after 20 weeks of gestation with new onset of any of the following. So it is not a problem if the preeclampsia is without proteinuria, as long as it has these followings: platelet count below 100,000 per microliter, and then serum creatinine more than 1.1 mg per deciliter, or doubling of concentration, transaminases to twice normal concentration, pulmonary edema, and cerebral or visual symptoms. And this is diagnosed after 20 weeks of gestation up to 2 weeks postpartum. So there is also another definition of preeclampsia based on ISSHP, which is defined as when the novel hypertension is present after 20 weeks of gestation in the presence of proteinuria and maternal organ or uteroplacental dysfunction. And how about gestational hypertension? Based on ACOG, gestational hypertension is new onset of elevations of blood pressure after 20 weeks of gestation, or often near term in the absence of accompanying proteinuria. So there is no proteinuria to be found. And based on ISSHP, when de novo hypertension is present after 20 weeks of gestation in the absence of the proteinuria and maternal organ or uteroplacental dysfunction. And then there is also the Iogenic markers that we can use to diagnose preeclampsia and can be distinguished between another confounding diagnosis. So what is the Iogenic markers in preeclampsia? Well, studies of high-risk pregnant women in their second and third trimesters using iogenic markers shows that an SFLT1 to PLGF ratio of 38 or lower, drawn at 24 to 37 weeks of gestation, can reliably predict the absence of preeclampsia and fetal adverse outcomes within 1 week. So the angiogenic markers here is SFLT1 and PLGF. And then they also have proved to be useful in distinguishing between confounding diagnoses such as chronic hypertension, and then chronic kidney disease and lupus nephritis. Preeclampsia is no longer divided into two groups as not severe preeclampsia and then severe preeclampsia, because if we do like that, it will make us tend to be not aware about the severity of preeclampsia itself, and also not so aware about the complication that might be happened during the preeclampsia. So we use the term preeclampsia and preeclampsia with severe features. What severe features are there? So the first one is severe blood pressure elevation. The blood pressure elevation can be called as severe if the systolic blood pressure is more than or equal to 160 or diastolic blood pressure is more than or equal to 110 on two occasions at least 4 hours apart while the patient is on bed rest. But this 4 hours apart doesn't mean that you have to wait until 4 hours to diagnose the severe blood pressure elevation. Since you found the uh, blood pressure is more than or equal to 160 per 110, you can give hypertension, anti-hypertension as soon as possible. And then the second severe features we found is symptoms of central nervous system dysfunction. So the new onset of cerebral or visual disturbance like severe headaches, scotoma, cortical blindness, and etc. will count to be severe features in preeclampsia. The next features is hepatic abnormality. The impaired liver function, that is serum transaminase concentration that is doubled or two times the upper limit of the normal range, or severe persistent right upper quadrant or epigastric pain that is unresponsive to the medication, is counted to be the severe features in preeclampsia. The next features is thrombocytopenia, which is defined as more lower than 100,000 platelets per microliter. The next feature is renal abnormality, which is we found the renal insufficiency that we found to be the serum creatinine is more than 1.1 milligrams per deciliter, or doubling of the serum creatinine concentration in the absence of other renal disease. And the last features is pulmonary edema. And also there is one last features that I forget to mention here is impending eclampsia. It can be grouped into the symptoms of CNS dysfunction, but will be specifically if I said as the impending eclampsia to make us more aware about the severe features of preeclampsia. So what we have to do if we have a patient on her early pregnancy, we can use this screening on early pregnancy. The screening is consist of the risk factor screenings and also physical examinations. The physical examination that we used is from her body mass index, which is more than 30, and then mean arterial pressure of MAP that can be obtained by adding systolic blood pressure plus 2 times of diastolic blood pressure divided to 3, and it is more than if it is more than or equal to 90, it have the risk. And also if the rollover test is more than or equal to 50. How to obtain the ROT is by um finding the diastolic blood pressure difference from left lateral recumbents to lying down within 5 minutes. So we measure twice. We measure the blood pressure twice. The first is when the patient is on her left lateral recumbent position, and then the second is when the patient is already lying down in 5 minutes. So if the difference between the diastolic blood pressure is more than 15, it tends to have the risk of preeclampsia. And the last examination is using another device that is ultrasound, uh, Doppler velocimetry, that we have to see the uterine arteries resistance and also notching. So the risk factor of preeclampsia is divided into two risk factors group, which is major risk factors and also minor risk factors. If you find any one positive points of major risk factors, it will say that you have the screen test positive, and if you have the two positive of the minor risk factors, you will say that you have the screen test positive. So what are the major risk factors? They are diabetes mellitus, autoimmune disease, history of hypertension, renal dysfunction, and also the finding of Doppler velocimetry to be have the resistance of artery uterina and or notching. And the minor risk factors are gemellli, primigravida, secondary primigravida, and age more than 35 years old, history of family with preeclampsia, and also the examination of body mass index, mean arterial pressure, and rollover test. If the screening tests positive, you can be used as prevention. The preventive is by giving the low dose aspirin about 100 and 150 milligrams before 16 weeks of gestation to 7 days before delivery. And also you have to give the patient with calcium supplementation that is mainly given at low intakes, that is lower than 400 milligrams per day, and Indonesia are considered as calcium low intake groups. So the dose is 1000 until 1500 milligrams per day given at 20 weeks of gestation. And also we have to give the patient with oral antihypertension to prevent complications due to hypertension like cardiovascular disease and CVA. And it doesn't mean that the target of lower blood pressure has been achieved during pregnancy, you are safe from preeclampsia or even eclampsia. It is not true. So the indication of oral antihypertension is when you have the systolic blood pressure more than 160 and diastolic blood pressure more than 110. The target is below the 160 and 110 during pregnancy, and if you have another comorbidities like diabetes mellitus, cardiovascular disease, and etc., the target will be lower than 140 per 90, and it is based on the recommendation of SOGC. There are also many types of oral antihypertension that can be given to pregnant women, but the first choice is nifedipine, that is via per-oral, and it is the group of calcium channel blocker. And another calcium channel blocker that can be used, but it is in intravenous route, is nicardipine. Another anti-oral hypertension is diltiazem and methyldopa. Methyldopa is a slow action and it is not aggressively lowering the blood pressure, so it is usually used for the maintenance and for the chronic hypertension during pregnancy. And you have to be aware that the side effects during postpartum of methyldopa is baby blues, so you better prevent to administer the patient with methyldopa during postpartum event. So now we are talking about the magnesium sulfate. Based on Persatuan Obstetric and Gynecology Indonesia or POGI, magnesium sulfate is indicated for preeclampsia with severe features or blood pressure more than or equal to 160 per 110. Preeclampsia with severe features must be admitted and administer magnesium sulfate. What is the meaning of severe features here? Like I said before, they are severe hypertension and also the finding of an organ damage and uteroplacental insufficiency. And magnesium sulfate also can be used as neuroprotectant for the fetus. And now we are talking about the administration of magnesium sulfate. If termination management is done, magnesium sulfate is given up to 24 hours postpartum, and if there is still seizure at postpartum period, it's given until 24 hours free of convulsion. If conservative management is chosen in early pregnancy, give magnesium sulfate in the first 24 hours when she first admitted to your hospital. And when 2 times 24 hours observation is safe and you decided to continue the pregnancy, continue conservatively and stop the magnesium sulfate. For example, after being treated for 1 week, it turns out that the conservative is failed and then you decided to terminate the pregnancy. So before we terminate, we repeat the magnesium sulfate administration. So now we are talking about the magnesium sulfate dose. So the administration of magnesium sulfate can be used uh, in 3 doses like loading dose, maintenance dose, and when you manage the seizure during pregnancy. The loading dose is 4 grams bolus and intravena slowly during 5 minutes to 20 minutes. There are 2 preparations of magnesium sulfate, which is 20% and 40%. It is easier if you use 40% preparation of magnesium sulfate. So we are gonna talk about the 40% only here, but you can still see the dosage of 20% magnesium sulfate in my presentation here. So if you use the 40% magnesium sulfate preparation, you have to dilute 10 millimeters of magnesium sulfate 40% in 1 milliliter of aqua for injection and administered it over 5 minutes. And then the maintenance dose is 6 gram and it is given by infusion or syringe pump with the rate of 1 grams per hour. So if you use the 40% preparation of magnesium sulfate, you need to dilute 15 millimeters of magnesium sulfate 40% in 500 milliliters of ringer lactate infusion, which is given over 6 hours with the rate of 28 drip per minute. And for the season management, you will have to give the patient with 2 gram bolus intravenous slowly within 2 until 5 minutes. We can use the both 20% or 40% magnesium sulfate preparation, and if you use 20% magnesium sulfate, you need to give the patient 10 milliliters over 2 to 5 minutes. And if you use 40% magnesium sulfate, dilute the 5 milliliters of magnesium sulfate 40% in 5 milliliters of aqua for injection and administer it over 2 to 5 minutes. And for the Caesar management, the administration is after the loading and maintenance dose are both complete. And it can be repeated maximum 2 times, and if the Caesar is still going on, there is unresponsive Caesar with magnesium sulfate. You will have to use diazepam. Magnesium sulfate and its administration have conditions or requirements to be met before administer it. So the conditions are normal respiratory rate during pregnancy, which is normally 22 to 24 times per minute. And then there is a positive of patellar reflex. Urine production is 100 milliliters per 4 hours before administration, and we have to have the antidote of magnesium sulfate intoxication, which is calcium gluconate 10% 1 gram or 10 milliliters in intravena. And don't forget to evaluate every 1 hours or before administer the maintenance dose. The management of preeclampsia is divided into termination and conservative or expectative. So I will divide the management of preeclampsia into two groups, which is management of preeclampsia and management of preeclampsia with severe features. First, we talk about the management of preeclampsia. For the term pregnancy, the termination of the pregnancy is at 37 weeks of gestation. And for the preterm pregnancy, we use the expectant or conservative management, which is we have a target that until the pregnancy reaches 37 weeks of gestation, when the baby is considered as term baby. And unless there are complications, we have to terminate the pregnancy at 34 weeks of gestation. And don't forget to close monitor. It can be the patient can be outpatient and can be treated at home if the pregnancy is still lower than 37 weeks of gestation. But don't forget to be more often to examine uh, the pregnant woman more often during the antenatal care, and also self-monitor of blood pressure at home is really important, and routine laboratory examination to evaluate whether there is a changes of the laboratory finding, and if there is any severe features, please go to the hospital or emergency room. And now, how about the management of preeclampsia with severe features? The termination of preeclampsia with severe features will take place at 34 weeks of gestation, and if the pregnancy is still in the preterm condition, you can do the expectant management. The candidates of the expectant or conservative managements are both mom and baby are still in a safe and in stable condition, and within the 2 times 24 hours observation, if there is any worsening event, you must terminate the pregnancy. If there is no worsening event, you can conserve the pregnancy to 34 weeks of gestation. Don't forget to admit your patient and prepare the ICU and neonatal ICU. Every hospital have their own facilities and different capabilities. So if you found out that there is less capabilities of your hospital to take care both of the mother and the baby, it is better for you to refer the mother as soon as possible, or we can call it as intrauterine referral. Usually, an ICU can take care of baby that is delivered at 28 to 34 weeks of gestation, and you have to know that the fetal survival rate of a baby less than 28 weeks of gestation is less than 50%. So once again, it is better for you to do the intrauterine referral if you see that your hospital is not capable enough. The lung maturation can be given for the pregnant woman below the 34 weeks gestational age by using the dexamethasone injection 6 mg intramuscular or intravena for 2 days. But don't let the lung maturation procedure prevents you to save the mother. So whenever you saw there is indication for terminate the baby, like there is worsening event, you must uh, act as as soon as possible to terminate the pregnancy. And preeclampsia with severe features is the indication of magnesium sulfate administration. So of course you need to administer the magnesium sulfate. It is not only for the mother, but is also have another benefit for the fetus, that is as neuroprotectant. Now we are talking about the intrapartum management. Cesarean section is still depends on obstetric indication, and don't forget to evaluate or monitor the patient to the fluid limitation and fluid balance. Oral antihypertension with target of blood pressure less than 160 per 110 is important, using the first line, that is nifedipine. It can be given when the blood pressure is more than 160 per 110, or even though the blood pressure is less than 160 but there is symptoms of an organ damage, you can give the patient antihypertension treatment. And also for the anticonvulsant, you can use the magnesium sulfate, which is 4 gram bolus intravena, or modified by dissolved it in 100 milliliters normal saline drips for 15 minutes. It is, as I said before, the anticonvulsant still using the magnesium sulfate. The loading dose is for 4 grams, but then you need to continue it to the maintenance dose, that is 6 grams. But if there is any another convulsion to be happen, you can administer another 2 grams. And last, we are talking about the follow-up of preeclampsia patient. Every preeclampsia patient have the risk of persistent hypertension, which leads to chronic hypertension and risk of CVA and cardiovascular disease. If your patient is in obese state, you need to advise her to lose weight and do the healthy lifestyle. You also need to evaluate and follow up the patient in 6 weeks, 6 months, and 1 year postpartum. Because in 6 weeks postpartum, if you see the persistent hypertension, you need to consult to the nephrologist and or cardiologist and do the laboratory evaluation. If 6 weeks and 6 months evaluation is no problem, there is no problem to be found, don't forget to still do the evaluation 1 year postpartum to do the cardiovascular risk test, because at that point the patient with preeclampsia also have the risk to develop the cardiovascular disease. Okay guys, thank you for your attention. That's all for this section. I hope you enjoy it. Thank you very much.